Welcome to this session on infection control in outpatient units. As healthcare delivery increasingly migrates to ambulatory and daycare settings, our traditional inpatient infection control models must evolve. This lesson explores advanced HIC protocols specifically designed for the kinetic perimeter, where high patient turnover and rapid clinical interactions create unique transmission risks that require precise, architecturally integrated solutions. Slide 2. The Paradigm Shift Matrix. We must first redefine our understanding of healthcare-associated infections, HAIs. The inpatient paradigm is static, focused on prolonged exposure and device-associated risks in wards. In contrast, the outpatient paradigm is kinetic and episodic. In this environment, HAIs encompass infections acquired during rapid, transient interactions in shared communal spaces. Our mandate is to shift from static containment to dynamic flow management. Slide 3. The bedrock layer, standard precautions. In high turnover settings, often seeing over 40 patients per day, standard precautions must be applied universally. This bedrock layer consists of 3 pillars. First, fluid barrier defense. Immediate availability of PPE to protect mucous membranes from unanticipated exposure. Second, point-of-care decontamination. Heavy reliance on alcohol-based hand rub, ABHR, as traditional sink washing is often operationally impossible between every rapid encounter. Third, environmental reset. Aggressive surface disinfection and rapid waste management between patient cycles. Slide 4. Threshold defense, respiratory hygiene. Our threshold defense begins at the entrance. We utilize administrative cues, such as prominent posters, to educate patients on cough etiquette. More critically, we implement source control by immediately providing surgical masks to anyone with respiratory symptoms, to block droplets larger than 5 micrometers. Paramedical staff then actively enforce a strict spatial perimeter of at least 3 feet around these symptomatic individuals. Slide 5. The Triage Switchboard, managing symptomatic patients. Symptomatic patients must not linger in the kinetic perimeter. We use a triage switchboard approach. Spatial segregation. If single isolation rooms are unavailable, patients must be separated by at least 3 feet or physical baffles like curtains. Administrative fast-tracking. HICC protocols must prioritize consultations for these patients, deliberately shrinking their ambient exposure time in shared clinical spaces. Slide 6. The dual fast-track matrix. We face an inverse challenge. We must fast-track the infected for containment, but we must also fast-track the vulnerable for protection. For immunocompromised patients, such as oncology or transplant recipients, we execute reverse fast-tracking. This involves immediate removal from shared waiting areas into specialized protective environments featuring positive pressure, HEPA filtration, and at least 12 air exchanges per hour. Slide 7. The perfect storm, hemodialysis units. Outpatient hemodialysis represents the ultimate challenge, a perfect storm of risk. We have a highly immunocompromised host population, intense vector intensity due to frequent high-volume blood exposure, and high kinetic velocity with minimal downtime between shifts. Consequently, hemodialysis is the second most common cause of mortality in this cohort, trailing only cardiovascular disease. Slide 8. Vulnerability mapping, the open hall paradox. The open hall paradox in dialysis centers prioritizes emergency visibility over infection control. The absence of physical walls or cubicles guarantees droplet perimeter violations. Furthermore, shared armrests, machine screens, and bedside tables serve as strong, rapid fomite bridges, allowing pathogens to move between patients in close proximity. Slide 9. The kinetics of contamination, turnover windows. Contamination is driven by the clock. An ideal 30-minute turnaround window includes discharge, exterior machine disinfection, internal pathway disinfection, and a sterile setup for the next patient. However, work pressure and understaffing create a failure state. When turnover is rushed, environmental surface cleaning is statistically the first protocol to fail, directly driving spikes in HAIs. Slide 10. The extracorporeal vector, vascular access. Vascular access management is our primary clinical intervention. Central venous catheters, CVCs, carry a 10 times higher risk of infection compared to arteriovenous fistulas, AVFs, due to the persistent breach in the skin barrier. For ID specialists, the mandate is clear. Maximal barrier precautions, including masks, caps, and large sterile drapes, are non-negotiable during catheter insertion. Slide 11. Securing the perimeter, the HICC mandate. Outpatient centers often suffer from an out-of-sight, out-of-mind vulnerability. To counter this, HICC must implement continuous oversight dashboard. This includes spatial audits to ensure segregation integrity, high-risk surveillance to enforce temporal adherence in dialysis, e.g. dedicated shifts for HBV/HCV positive patients, and strong HHAR rapid cycle tracking to measure hand hygiene compliance within the high workload realities of ambulatory care. Slide 12. Engineering the safe outpatient ecosystem. In conclusion, infection control in the modern ambulatory era cannot rely solely on clinical interventions. As ID specialists, we must act as systems engineers. By mastering spatial architecture, administrative fast-tracking, and rigorous auditing of microenvironments, we design the operational blueprint that secures the healthcare perimeter before an infection can ever take root.